Thank you, Amit, for this opportunity. And till now, what we have discussed about Thymoma, I think most everything has been covered. A very nice presentation by Dr. Rajiv sir, and then by Dr. Prashant sir and Dr. Anil has covered all the radiotherapy part, and Dr. Vikas too has left nothing back. So we will just have an overview and a simple discussion about the management of Thymoma in routine clinical practice. So I'll just give a clinical scenario, and based on that, we will have a short discussion. So coming to this is a 45-year-old lady without any comorbidities. She presented with a complaint of dry cough for around 3 months and hoarseness of voice with shortness of breath for 15 days. There was otherwise no history of any fever, hemoptysis, or bleeding manifestation to this mission, and she hasn't received any blood transfusion too in the recent past. On evaluation, she was a COG PS2 with no parallel cyanosis, no lymph nodes was palpable, but there was a facial puffiness with neck veins were engorged, though the otherwise chest, CVS, and abdomen were mostly normal. The initial investigation, the patient showed is about normal hemoglobin for this, with a normal differential count. LDH is 2 in the normal range. The CT is showing a soft tissue dense mass, which is a homogeneous with central necrosis in anterior mediastinum, extending from something around level of manubrium to right atrium. Size is 12.3 into 6 into 10 centimeter, and it is abutting the left brachiocephalic vein and SVC, but maintaining the fat plane with ascending aorta, with focal loss with pericardium, and coarse calcification was noted within the mass. Otherwise, the lung parenchyma was normal, no pleural effusion, no involvement of bony structure. So basically, it's a mass with a central necrosis and just abutting the veins, and with focal loss with involving the pericardium too. So now this is a 45-year-old female with anterior mediastinal mass with a superior vena cava obstruction. So the initial question is, what are the possible initial differentials? So my first question will be to the surgical oncologist surely, because the patient first goes to them. So sir, Dr. Prasant sir, so what do you think initially?
Yeah, so a mass in the anterior mediastinum in a 45-year-old, I would put something arising from the thymus as the first. As the CT mentions, you have more in favor of a thymic carcinoma, or even probably a high-grade thymoma, not definitely not an A or a B1, or it's not an early. The other thing which I'm also very keen, which I would specifically look for, because you have actually mentioned patient as hoarseness of voice. So, what about AP window? Because with the similar CT findings, I don't expect a patient to have hoarseness of voice. So I would carefully look at the AP window. And then if the AP window nodes are involved and other mediastinal lymph nodes are involved, then my differential diagnosis would be of the small cell or neuroendocrine originating from the thymus. These are some things which I would want to look for, because clinically patient is having hoarseness, then I am concerned about the AP window nodes, because when it's not that it's not uncommon, but my differentials would change depending on that. But most likely it would be because germ cell tumors at this age, no. Lymphomas without any other B sign symptoms and other things, I would keep it low down the order. It's something arising from thymus, or it could be a small cell carcinoma.
Yeah, surely, sir. Agree with your sir. Anil sir, any changes from your part, or you are agreeing with the diagnosis or differentials which we are keeping?
No, I agree with Dr. Prashant that I would also keep small cell lung cancer in the differential, only because that there is a focal loss of pericardium and hoarseness of voice. And so the majority of the small cell lung cancer also present with the mediastinal nodal mass, so which can obstruct or which can present very similarly to the thymic carcinoma or higher grade thymomas.
Sure. Dr. Somnath, any changes from your side?
Hi, Amit. No, actually, these things, the possibility is definitely first for the thymic origin, thymoma, high grade, or thymic carcinoma. Then there is a possibility of small cell tumors, small cell lung cancer, and definitely lymphoma, primary mediastinal B cell lymphoma can also be an option in this DD. Although this classical features is not there, but sometimes is the age group and the gender and this SPCO quietly match from the PMBCA. It is, but definitely it will be the least possibility, but this is the option.
Yeah, surely the more common things comes more commonly. Dr. George, your comments?
Sir,
I think so. Dr. George, you are not audible. Okay, so surely this patient has basically presented with a feature of SVCO, so something aggressive disease is there. So we surely what is the most commonly see is the small cell. Is a small cell lung cancer or really a thymic carcinoma in this patient. So the DDs, as we have already know, the thymoma, and from the anterior mediastinum, since the CT is showing in this group of patients, so thymoma comes initially the first in the list, followed by carcinomas or teratomas rarely with in this group of patients. So just I think so, Dr. George, you are not audible. Your connection is poor. You may rejoin. I think so, it will be better. Okay, so the presentations have already been discussed, so I'm not going in that regarding whether it's how does the patient present with the local symptoms like SVCO in this case of patient, or with a paraneoplastic manifestation, which we are not seeing in this group of patient. But thymic carcinoma surely are more aggressive with less extrathoracic metastasis as compared to others, with only less than 7%, though the liver and the bone are the most common site which it presents with. And since this patient is neoplastic, as we have already been discussed, I'm not going details in this. But the points of myasthenia gravis has been greatly covered by Dr. Prashant. So I move from here. So now regarding how to proceed with this patient. So Dr. Prashant, coming back to you. So how will you do the initial investigation if this patient with SVCO and sometimes shortness of breath will come first time in the OPD?
Yeah, so this patient, we have only few differentials. The list what you pointed out, so mine is more in favor of a small cell or a thymoma with probably an aggressive variant. And sure. I'm not going to take the patient for upfront surgery without a biopsy. I'm not very comfortable with the clinical presentation. So I would go in for a biopsy. So from the mediastinal mass, and then depending on the biopsy, I would do a PET. If it comes as thymoma, high grade, or a thymic carcinoma, then probably role of PET is very limited because CT covers most of the things. If you just cover an abdomen and adrenals, most of the thing is taken care of. But yeah, if it comes as a small cell, then the management is going to be completely different. Even the workup, diagnostic with an MRI, everything adds on to it.
Yeah, great. So, and sir, in which cases are you going for upfront surgical resection, not going for a biopsy?
Yeah, so the upfront surgical resection is something which you have a very well encapsulated lesion. You know that the planes are very well maintained, and you can get the mass en bloc without causing a breach in the capsule. So these are patients where I wouldn't want to do a biopsy and cause a breach. So here you have a patient, though the planes with the brachiocephalic and SVC seems to be good, but patient is having clinically superior vena cava obstruction with hoarseness of voice and probably something in the, I'm not very comfortable going. I would want to get a biopsy and then take it forward.
Yeah, sure, sir. So basically this patient has also undergone an FNAC at that time, but which was clearly at the center is showing the features of thymic neoplasm. So now coming to Dr. Tripti ma'am. So ma'am, are you comfortable with the FNAC doing in this kind of patients, or you need a biopsy to diagnose?
So sometimes in FNAC it becomes very difficult. Am I audible?
Yes, ma'am, you're completely audible, please.
So it becomes very difficult, though there are some diagnostic features. I mean, if you see a large number of epithelioid cells, the problem comes when it is like a B1 kind of thymoma, like entirely immature T lymphoid, and you may misdiagnose this as T lymphoblastic. So that is one gray zone in which you are very skeptical, because that is mainly diagnosed on biopsy with the meshwork of the cytokeratin that you see, and you hardly see any epithelioid cells. So for me, biopsy is preferable and not FNAC.
Sure. So are you going to do ISC also on these kinds of patients of thymoma? And at least which ISCs are the initials at least needed?
Sorry, can you repeat?
Ma'am, role of ISC in diagnosis of thymoma. So are you doing ISC also?
Yes, yes. So basically any mediastinal mass, first you see whether it is lymphoid predominant or epithelioid predominant. So mostly type A, which is like epithelioid predominant spindle cell morphology, your IHC should be mainly cytokeratin, 1-TDT and Paxate. So Paxate comes in epithelial, which shows thymic origin. And then if it is type A, we also put like CD34, which will differentiate it from SFP. It has a very mesenchymal look. And moment the B1, B2 and everything starts, so it is more of lymphoid cells. So all there will be a sea of TDT positive immature, but the A1, A3 meshwork will help. So that is for B1 versus T lymphoblastic lymphoma. And when it comes to thymic carcinoma versus thymoma, there are some markers like CD5 and c-KIT which will help in defining carcinoma. So there are some important roles of IHC.
Sure, ma'am. Great. Yeah. So basically we have initially to look for the morphology, and based on the morphology, the ISC has to be put in these group of patients. So radiological features has already been discussed, that the CT is the most initial investigation we are doing in these patients. And if there's a thymic carcinoma, these patients may have more necrotic or cystic or calcified areas as compared to the thymoma, which as already said is a homogeneous engulfed masses. But CT finding are also different. Somehow we can see in a different type A, B or C. It may be somehow in type A, it's a rounded smooth, whereas in type B, there may be more frequent calcification, whereas type C, as we know, is showing the invasion. MRI role has already been discussed. It's rarely needed, but surely look for the neurovascular bundles. And sometimes when we have to look for the hyperplasia, and if we are finding it difficult to differentiate from any cystic lesions, in those cases, PET surely have got a limited role in thymoma, but surely in thymic carcinoma, it has got a role in this group of patients. So this, since we have discussed about the tissue diagnosis, is compulsory surgery. As already discussed by Dr. Prashant, that based on the CT finding, we can go for upfront surgery in this course patient, but for thymic carcinoma, surely is planning to do this biopsy upfront. So as we already know that definitive diagnosis is going with a surgical resection or with a core needle biopsy. ISC markers, ma'am has already discussed different, and in the initial we have already discussed. So now regarding the staging, again coming back to Dr. Prashant sir. So which staging at present are you following? So there are now multiple stagings which are right from the Masaka-Koga to now the TNM. So for resectability, what are you considering now, sir?
PECT chest with abdomen is the gold standard, and that gives us most of the details. I would say 99% of the times I'm happy with that. Very rarely that you would want an MRI of the chest, very rarely, but that situation may not arise, because if you're asking for an MRI, the disease is definitely locally advanced, and you are not going to plan for an upfront resection for sure. So the role of MRI in initial thing is, it's always debatable. I'm sure that PET would pick up so many things elsewhere, but in thymoma or thymic malignancy, there is no level 1 evidence to recommend PET routinely. The most common site of metastasis is pleural metastasis, which can be picked up by a good CT scan. And if you cover the liver and the abdomen, the adrenals, CT is actually good enough. A PET may not add over and above, and the evidence is limited. And mind you, in a patient with an anterior mediastinal mass, which you've already mentioned here, always evaluate for myasthenia gravis. Do not do the mistake, because 50% of them do have these symptoms, and ACH, at least an anticholinergic antibody, should be sent in these group of patients before you embark on any form of surgical treatment for these patients.
Yeah, sure, sir. Points well taken. So this is just a flowchart. Basically, regarding your comments about the tumor markers. So since he's a lady, we rarely see a mediastinal germ cell tumor. But if it has been a male, so you would be going for the tumor marker upfront for this group of patients?
The age is very important. So 45 years and the radiological findings. Radiological findings also help. The only radiological finding in this patient was, calcification. Something that, that can happen over chronic testing. So that's the only age. Yes, tumor markers would be required. I agree 45 is something on the borderline. If your patient was a decade earlier, my first choice of investigation would be tumor markers, because You don't even need a biopsy at that time if you have positive tumor markers.
Sure, sir. So, yes, sir. Now, coming back to stage, this question basically to and Dr. Anil, sir. So, what are you now following? It's a modified Masoka staging or the TNM staging? So, we are comfortable with which one nowadays?
As far as the staging is concerned, I think the most commonly used is the modified Masoka Koga staging system. However, it is preferable to add TNM staging also for the uniformity between the database, because thymomas are generally rare type of tumors, and we will not be able to get the data if we are not doing a uniform staging system. So as Dr. Rajiv has already mentioned in his talk, that we should both report the modified Masoka Koga staging as well as the TNM staging. So because ISLC and ITMIG both group have mentioned that the thymoma and thymic carcinoma should be staged according to the AJCC 8th edition. But yes, historically the modified Masoka Koga staging has done pretty well as far as the prognostication of the surgical patients are concerned.
Yeah, completely. Getting back to Dr. Prashant, sir. So, if you're taking the patient for surgery, so are you going for everyone, or the resectability is being defined as we see in the TNM staging from stage 1 to 3 are considerable?
Yeah, T1. I mean, like T3. It depends on the extent of involvement. I wouldn't consider all T3s as resectable tumors. So yes, technically yes. So you can go ahead and resect superior vena cava. You can resect the chest wall. You can resect, the brachiocephalic lung can be taken. So that's not what is important. Here you're trying to make sure that you're. The most important thing is not having any residual disease during your surgery. Okay, so that Anil can help us by doing. But if I do an incomplete job, then even Anil is not going to say, "Oh no, boss, you have left a gross residual disease behind." Okay, so leaving behind gross residual disease, then asking Anil to help, I don't think is correct. So your primary aim should be to achieve an R0 resection as much as possible. So I wouldn't consider even T3 as an upfront resectable disease. I would biopsy these group of lesions.
So, sir, if you are getting a patient, if you are not getting R0, you're thinking if at least R1 you are getting. So, are you planning to give something new adjuvant and then to take for surgery, or R1 you are going for upfront surgery?
Yeah, I would work out the feasibilities for some form of neoadjuvant treatment if I am not actually going to achieve an R0 resection. See, there's a subtle difference. It is R0 or R2. R1 is something which Dr. Trupti has to. R1 is something that which Dr. Trupti has to tell me based on my intraoperative findings. So because the capsular breach and something like that, it's R2. If I can make out that I have left something behind, it is R2 resection. So just to be clear, so there is no R1 that I can make out. So it is either R0 or R2. So yeah, I would bang on. I would err on the side of giving some form of neoadjuvant.
Sure, sir. So yeah, coming back to Dr. Tripti ma'am again. So ma'am, this is what we have discussed about the histopathological features of differentiating between thymoma and thymic carcinoma. So the first thing what we have said is about you look for the spindle epithelial cell. So type A means, can you just elaborate how you'll differentiate between type A and type B in this group of patients?
Okay. So first of all, when you get a biopsy, just see whether you are seeing lymphoid cells more or epithelial cells more. That is the first thing. When you see mainly lymphoid cells, it is one of the categories of type B. So that is that. If you are seeing epithelial cells, then you categorize whether it is spindle or it is polygonal. If it is predominantly spindle without any admixed lymphoid cells, it is more of a type A. And then there are cases where you see admixture and you tell that whether it is type AB or not. When it comes to B, like type B1 will be entirely lymphoid cells. You have to hunt and then you actually think of lymphoblastic lymphoma and you get a measure. That is how a B1 will look like. In B2, there will be a lot of lymphoid cells, but then you will see clustering of epithelial cells and you will call it B2. Now, important thing is to differentiate B3 versus thymic carcinoma, which is very difficult when it comes to biopsies. In resection, yes, you see a lobulated pattern. But in biopsy, you just get a core and you can't. So that time you will correlate with imaging whether the neoplasm was lobulated. So B3 versus thymic carcinoma, both will show little epidermoid features, some atypical features. But when it comes to thymic carcinomas, I said there are some IHC markers which will help, positivity will help you tell whether it is thymic carcinoma or not. So that is the overall scenario. And then you put IHCs accordingly.
So for thymic carcinoma, it is CD5 and KIT, which you are saying is
yes,
they have to differentiate from
yes.
B3.
And sometimes you say obvious carcinoma with lot of keratinization and glandular features or whatever, then it is very easy to call that it is a carcinoma.
Yeah. Okay. Thank you, ma'am. So now again the question for Dr. Prashant. So the criteria for resectability you have, sir, already discussed. If there is an R2 resection, you are getting something you are not finding, you are completely going to resect those patients. You are going for the neoadjuvant therapy. So which structures, surrounding structures, you makes that tumor unresectable?
Yeah. So technically speaking, deep infiltration into the pericardium with infiltration into the chambers of the heart is something which makes it completely unresectable. So otherwise, phrenic can be taken care. Bilateral phrenic, dangerous, but then yes, I mean, it's very uncommon to have bilateral phrenic involvement. You can left brachiocephalic, superior vena cava, arch of aorta, all these things can be taken care safely. But it depends on the expertise of the center. You need to have a good cardiac endovascular backup. You need to put these patients, but deep infiltration into the cardiac chambers or in the middle mediastinum with extensive nodal involvement, tracheobronchial tree, major tracheobronchial tree, extensive lung. There are a few case reports where they have some of the authors have done pleuropneumonectomies for extensive thymomas. That is, centrally located lesions. But those are just confined to case reports. So we do not know whether it would really add on to the survival or not. But yes, these are the points where we could consider for resectability versus unresectability.
So do you consider cytoreduction as a part of treatment in this group?
Yes,
patients?
Yeah. Gross, cytoreduction does help when you know that you have given some form of treatment and you have no other choice. Then cytoreduction also has shown survival advantage over not doing anything in this group of patients. But majority of them, it is actually quite challenging. We may think that, okay, try open up the thorax and take out as much as possible and come out. But it's quite challenging. Cytoreduction, whatever evidence is available, yes, it does. Personally, yes, I do not have experience much on that, but yes.
So what is the role of minimal invasive? Are you routinely doing minimal invasive surgery in this group of patients?
Yes, for localized lesions. So I confine myself for a VATS. I generally confine to 5 to 6 centimeters is what is my cutoff is, and what literature says is also about 5 centimeters. But for robotic, after the robotic, because the chances of the handling the thymus, okay, we are all worried about rupturing or causing injury and spillage. So there is safety data till about 8 centimeters, but there are a few case series even beyond 8 centimeters, but I'm not very sure whether you should be doing for larger lesions because you don't want to cause a capsular breach and make it more worse. Minimal invasive is a safer approach for highly select patients. For non-thymoma, if you're doing in myasthenia gravis with non-thymoma, definitely minimal invasive surgery adds on a quicker recovery in these group of patients rather than a sternotomy. But mind you, don't compromise on the extent of resection. It has to be a radical thymectomy.
Okay, so points well taken, sir. So now coming to Dr. Anil, sir. So RT is the main adjuvant now in this group of patients with thymoma and thymic carcinoma. So what are the, you have discussed already in your slides. So just to brief once again, what are the doses which we are using in the radiation for thymoma patients and in thymic carcinoma, if there is an R0 resection and when there is an R1 resection?
See, the most important point here I would like to highlight is that the post-operative radiation therapy in thymoma is not based on randomized control trial. It is based upon the retrospective data and the guidelines that the expert has given. So it's not always that you should consider stage 2 to stage 4 thymoma always. So depending on the pathological classification, the inputs from your thoracic surgeon, whether they are, how well they have done the surgery, whether there is any doubt about the margins or about the residual disease, what is the pathological classification A, AB, B1, B2. For example, if it is a stage 2 but type A tumor, I would not offer the patient adjuvant radiation therapy. So the chances of recurrence in stage 2 type A will be less than 10%. And if the recurrence happen, then the surgery, if it is possible, will give you a longer overall survival. Only in stage 2B, B2, B3, I would be very comfortable in offering the radiation therapy to decrease the chances of the relapse. However, but the database has shown that there is an overall survival improvement. We should not or we should not take that with a very hard level of evidence, because these are just the databases. We don't know how the databases are entered. Even if it is a US or National Cancer Database, we need to carefully look at the data. As far as the doses of the radiation therapy is concerned, if it's an R0 recession, then 45 to 50 gray is more than sufficient. There is no need for any dose escalation over there. 45 to 50 gray will take care of your microscopic disease. But if it's an R2 recession, or if it is an unresectable thymoma or thymic carcinoma, then yes, to the gross disease, a dose of 60 to 66 gray in 30 to 33 fraction once daily regimen is required. As far as the delivery technique of radiation therapy are concerned, mind you, so these are the treatment which we are going to offer because we want to reduce the local recurrence rate. Okay, so we should not give radiation therapy when there is a very large post-operative tumor bed, and we should always discuss with the thoracic surgeon, like Prashant has already mentioned, that it should be a multidisciplinary tumor board approach between the thoracic, the surgical, between the surgical, medical, radiation, and the pathologist as well as the radiologist. And in unresectable cases, doses should be 60 to 66 gray, and we should always take the help of thoracic surgeon as well as the pathologist while we are defining our target volume. It is very important.
Yeah, sure. Thank you, sir.
Dr. Amit, if I may ask a question to Dr. Anil.
Yeah,
Anil, what's your take on pre-operative, like, in totally unresectable neoadjuvant sort of a radiotherapy? I know I'm not very sure whether I can call it neoadjuvant, but pre-op RT, and what's your experience with the same?
So, Prashant, frankly speaking, we haven't offered any patient the approach of neoadjuvant chemo radiation or neoadjuvant radiation therapy. So because whenever the patient is unresectable, so mainly because of the tumor size and the infiltration into the adjacent structure, and then the possibility of as the thymomas are not very high grade type of a tumor, means the proliferation rate, so they will not respond very quickly, so that the patient can be resectable in a 2 months time. It will take time to respond to radiation therapy. So I personally haven't offered any patient neoadjuvant chemo radiation therapy to make them resectable. However, the main treatment regimen is the neoadjuvant chemotherapy. If it is become borderline resectable to resectable, then yes, the surgery can be offered. Neoadjuvant chemo radiation therapy is largely experimental, I would say.
Sure, sir. So the next question was similar about these unresectable tumors, whether to go for a definitive chemo radiation or versus an R2 resection followed by the adjuvant therapy. So
I think largely this decision depends upon the surgeon. So because if they are comfortable in pre-operatively, if they think that they could reset the tumor with an R0 recession, however, when you when you open the patient, as Dr. Prashant has already mentioned, if they found that the tumor is not completely resectable, then yes, they should do a maximum safe recession, and they should put the surgical clips. So I would say that upfront surgery or neoadjuvant chemotherapy followed by surgery, and then the post-operative radiation therapy will be a better approach. So because this has the largest data as of now. But if the patient is completely unresectable, as Dr. Prashant has already mentioned, then yes, so definitive chemo radiation will be a better option.
Yeah. Okay. Thank you, sir. So now coming to the role of concurrent chemo, sir, you have already discussed. To coming to the medical oncologist. So Dr. Somnath, if we are planning for a concurrent chemotherapy in this group of patients, so which chemotherapy regime are you going to take?
Yeah, definitely. If a concurrent chemoradiation is planned, although we have not so much robust evidence of which is better because there's scarcity of a large-scale prospective randomized trial. So as of now, we extrapolate the data from role of chemotherapy. Cisplatin is will be my choice with a weekly or 3 weekly based regimen according to the creatinine clearance GFR and patient performance status. So platinum will be the ideal in this situation when concurrent used. And apart from these, we can use the cisplatin etoposide base also in some cases.
Yeah, surely, completely agreeing. Cisplatin etoposide, though the studies are there with the cisplatin and etoposide, though we may rarely go with the cisplatin alone in this group of patients. So coming to Dr. George, so palliative chemotherapy options. Do you think that they have got any advantage if the patient is completely unresectable and you are not getting any not able to go for surgery or chemoradiations? So palliative chemotherapy has to be given. And what are the chemotherapy regime are you planning in this group of patients?
I would like to first assess the fitness of the patient, and if the patient is cisplatin eligible, then I would like to consider chemotherapy regimen with cisplatin combination with cyclophosphamide and doxorubicin cap regimen. There are also other regimens with cyclophosphamide, doxorubicin, vincristine, and cisplatin regimens. But this can be given only for fit patients with patients who can be cleared for cisplatin. If the patient is based regimens, then paclitaxel, carboplatin.
Okay, fine. I think so. We have lost Dr. George. Coming to back to Dr. Somnath, are you planning to do NGS in this group of patients?
Frankly speaking, as of now, we are not doing routine NGS in this case because we don't know what are the targets and the role of targeted therapy with the base of NGS still in an experimental study. So outside clinical trials, it is difficult to do a routine basis in NGS. And these things, some data will be there, are there regarding this target of EGFR, c-KIT, and these things. But still, it is all are experimental, I think. So we are not. I don't recommend routine NGS in this case, unless until it is a metastatic and failure to the first line therapy. Patient is very keen to take some therapy which are sometimes facing in our clinics. In that case, we can look at the NGS.
Yeah, okay. At this point, I want to take the opinion of Dr. Tripti also. She is a routine part of our molecular tumor board. So, ma'am, are you if the patient has relapsed after the first therapy she has received, so NGS is an option for this group of patients?
Actually, if you see thymic carcinomas or anything, most of them have the copy number variations, like most of it, and there are some mutations, and mostly you get P53 mutation, especially in carcinoma. So not much targetable mutations that you see. So as of now, I'm not that convinced for the role of NGS as such in, and whatever cases also, few cases that we have got, we have the similar profile. Not much target that we have found.
Yeah, surely there are only few targets and the most common drugs which we are using here might be sunitinib and lenvatinib in this group of patients. Apart
Amit,
from
Amit, sorry to interrupt. Can we conclude in the next few minutes?
So the last thing is about immunotherapy in the later lines. They has got some role, but surely not in thymoma, as there are, everybody knows there is a large number of immune related adverse events in these group of patients. Otherwise, in thymic carcinoma, surely if the PD-L1 expression tumors are there, there is some role of immunotherapy in second line or third line in this group of patients. So I thanks all the panelists for their great discussion, and I think the whole thymoma part and thymic carcinoma has been covered today, and all the doubts have been cleared of all the persons who are listening to this panel discussion and also the initial talks by the all. So thank you, everyone.
Thank you. Dr. Amit, sorry, one last question I wanted to ask. Like imaging findings was like necrosis, like central large areas of necrosis, and biopsy you got just suggestive of thymoma. So are you thinking that you have some missed any high grade areas in biopsy? And in such cases, are you looking for any subtype of thymomas? What do you expect from a biopsy?
So
Just-
surely in this group of patients, the finding is more in favor of thymic carcinoma because of the large number of necrosis and the picture, the patient aggressiveness disease they have presented. So we'll surely, though the FNA has been done in this patient, we'll surely plan for the biopsy in this group, this patient. And we have to rule out between thymic carcinoma or an aggressive B3 type of thymoma in this patient.